you know, the topic for physician in the United States, and then also for people who practice medicine in Vietnam, and you can see the data, which is quite interesting. And then we go to the model that everyone uses here in the United States. We call the spikes model, and then we at the end, I think that after T. Helen talks about the DNR, DNI, then we're gonna have a chance to talk about to practice a little bit. So why do we need to know about delivering bad news? A physician, our job is to make the diagnosis, but not only making the diagnosis, but we also have to deliver the diagnosis or the bad news to the patients, right? But the thing is that, the healthcare module have moved toward the patient-centered care, meaning that you really have to put the patient in the middle. Everything is for the patients. So in the United States, as a physician, you are expected to know this. These are essential skills that they taught a lot in many medical school and residency. And if you are planning to take the USMLE and practice here in the United States, they are frequently tested on the test. So there might be one or two questions. So these are freebies if you know the gist of it. So I think it's useful to know about it. And then the second thing is ethical responsibility, right? As a physician, you are expected to provide a truthful information, and this is also to respect the patient autonomy and dignity. You are expected to give them the information, and based on that information, the patient will make their own informed consent and the decision about their own health. Also, this is also to build trust with your patients and also the family members. I mean, there's nothing more sacred than being able to talk about something so deeply, connected between you and your patients, such as a life-threatening, diagnosis and something that will change their life for forever. So it is quite sacred. The last part, and not least, is also the legal implications. Depends on how you deliver the information. You really have to learn how to do a good job to prevent any misunderstanding and misinformation, because again, the patient might interpret the wrong way, or the family members might interpret the wrong way and end up, it could be a mess. They could sue you, you could be in legal disputes, and that's just really a headache for any the patient and also for the physician. So we really need to know how to deliver in an appropriate way so that to avoid the legal implications. So what is considered bad news, right? So the bad news by definition is any news that adversely or seriously affects the individual view of their future, right? And could be a life-threatening or some condition with very poor prognosis. For example, the most common is cancer. But beside cancer, you also have other conditions like neuroprogressive degenerative disease like Alzheimer, or people with advanced heart failure. They are expected to have a shorter lifespan with advanced heart failure, or someone who with autoimmune disease. Again, these are serious conditions that will require them to be on a very serious medication. So, it can be very a shock for the patient. Or someone who have severe injury, after they have a motor vehicle accident, now they have a spinal cord injury. Now their life is forever changed. They can't move anymore. Or someone who, really want to be a parent. Now they have a miscarriage, or the infant was born, but they are born with some very serious health issues. So these are very, it's very distress for the patients and also for their family members. Or someone who have a failed treatment, they have a failed surgery, they have a procedure that really didn't work for them. So why is delivering bad news so difficult? Well, these are considered to be very stressful for a physician, right? Because, as a physician, you really want to, bring good news for the patients. You want to be able to tell them that they are cured, their disease is gone, but a lot of times that's not how it works. Sometimes treatment don't work. Sometimes it's just the way it is, but we really have to have a way to explain to the patient. And also it's difficult because, the lack of education and training, these are not taught in a very early stage. Many years ago, 20 years ago, physicians are not taught about this. It's only been recently. So I think that, it's becoming more popular and popular among a medical school. So that's why now they get more training and also more communication skills being taught in medical school and in residency also. So these are some of the statistics, right? So this is based on the annual meeting of the American Society of Clinical Oncology. So oncology are cancer doctor, right? So part of their job is to deliver bad news or cancer to the patient. So this is why their number is quite high. You can see that about 10 to 20 times is almost one third of them. And then one third of them is between 5 to 10. And the other two is more than 20, is maybe 110, and then less than 5 times is about 22%. What about you guys, people in this class? I appreciate people who actually answered the questionnaire. So there was 21 responses, and a majority of you guys are about 3/4 of you guys do it less than 5 times in a month. I think which is reasonable for people who are not oncologists because they may not have to do this very often. Only about 9.5% do it 5 to 10 times, and about 9.5% do it 10 to 20 times. So I think these people are dealing a little bit more with life and death situation. And again, there's someone who said they're less than 2 times because their major is rehab, which is, understandable. And among all the tasks, which one do they find the most difficult? There's discussing the diagnosis, telling patient about the recurrence, talking about palliative treatment, discussing about end-of-life issues, or involving family and friends or of the patient. Most people find it difficult to talk about palliative treatment and telling the patient about recurrence and discussing about end-of-life issues, which is very similar to people in our class. Again, half of you guys think that talking about end-of-life treatment is difficult. Again, telling the patient about recurrence and also discussing about end-of-life issue, difficult. So the next question is, how many people in the oncologists have got training? A majority of them actually just sat with a clinician. So this is basically observing. Only a very small amount have formal training or formal teaching. So this is very small, but a small amount of people actually have both. But it's still one third of them do not have any training. So again, even in the United States, you can see that these are not something that being taught frequently. So they just started doing it recently. So this is why I think it's only one third of them have neither experience. But I think if you survey resident or medical students, maybe graduate in the last 10 years, I think the number will be a lot higher. So what about our class? A lot of people have neither. So half of you guys actually do not have any training or do not even have any observation with someone who breaking bad news interviews. Only a small amount of people actually have both, 13.6, and about 22% of you guys have observed something, and 18% actually have formal teaching. So this is actually higher compared to the United States. So I'm quite happy that you guys are getting the training for that. So, they asked the physician, like, how do you feel about your ability to break in bad news? I have to say that, actually quite some people feel comfortable with it. 41% think they're good. 41 think they are fair. 12% think that they're very good. They're like expert. Only very small amount of people say that they're poor at it. And our class is a little bit different. Okay, so I think that no one claimed that they're very good. A majority of people actually think that they're fair, but you still see that a lot of people that still think that they're poor at delivering the bad news. Only about 9.1% think that they're good. So I think this is probably is because of the lack of the training and also the education that provided to you guys. So I also wonder, how do you guys deliver bad news to the patient? Because here in the United States, in every single hospital or clinic, they always have a private room, or we call family room, that, often the patients and the family can meet with the physician in that room to talk about, the end of life issue or some serious important issues. But in Vietnam, it sounds like You do have some private room in the clinic and hospital for that. I still quite surprised that about 13.6% are delivering bad news at the bedside. And it might be, appropriate in Vietnam, maybe to the lack of space, but I really don't think that's appropriate to deliver bad news really at bedside, unless, the patient is really intubated and they cannot move and you cannot really do anything else. And then 22% actually do not have a designated place for this. And very small amount have, they usually do it in the private area in the ED. Okay, so the models that we will talk about is called spikes. The first is setting, perception, imitation, knowledge, emotions, and empathy, strategy, and summary. And this is spikes. I don't know these people. For those who play mobile game, this is a Brawl Star, and the character name is Spike. So I think it's easier to remember. So the setting. Think of before you even breaking bad news or deliver bad news to the patient, think of it as like a battle. You want to go into the battle prepared. Even before meeting with the patients, you really have to find a place, an appropriate environment. Somewhere it's private, somewhere it's quiet, and there's no you have to distract that can cause disruption to the meeting. So again, we avoid public areas like the hallways, the ED, or even the ICU. We really have to have a private room where everyone can sit and talk. We want everyone to be comfortable, so everyone should be sitting down. Sitting down is you have eye to eye level to the patient and to the patient families, so that way you can tell their emotions. And try to avoid standing up and looking down on them because that can make them more anxious and more nervous by looking up to them. Okay, so I think if you have kids, you will understand it's easier to talk to a kid when you're at their eye level than standing and look down on them. Sometimes they can't really see you. The third thing is you really have to limit distraction in that no cell phone, turn off your cell phone, turn off your beepers, again, your pagers. This is real to respect their time, and this is their time so that you can talk to them. In the United States, before talking to delivering the bad news, you usually have like a whole team, medical team, like a nurse, the case manager, the social worker. The most important thing about this is that before meeting with the families and the patient, all of you guys should have a hurdle first. Like you have to meet with each other first and come up with a plan. Basically, everyone should be on the same page. You can leave it into the meeting and everyone have different plan for the patient. So talk ahead of a time first before you meet with the family so that you guys are on the same page. Family. So some patient would have, very difficult family dynamic. So we have to ask the patient if they want the family member there or their friends there. Everyone have different situations. So some people will want their children to be there with them. Some people really don't want their sister, brothers to be there with them. So ask them and respect their opinions and the decision. So perception, what does perception means? Perception is basically you want to know what does a patient know about their disease before you tell them anything, okay? Some patient will have very little insight of what their disease, maybe because of lack of education, they're not educated, they don't know much about medicine. So this is why it's good to know about what do they know about their disease, right? So you can ask them using an open-ended question. So you can ask them like, what have you been told about your medical situation? I know that you have an MRI. I know that you have a PET scan. What are your understanding of the PET scan? And based on their response, you can tell if they know anything about the disease or they are absolutely clueless. And then don't forget checking with the family members. Some family members will know medicine, some don't. So this is also a time to gauge, their involvement and then their understanding of their family or the loved one of the medical conditions. So after knowing their perception, the next thing is you want to ask them, you want to invite them. You want to ask them, how do they want to know the information, right? Some patients, especially in Asian community, you know, the child always tell the patient, the doctors, like, don't tell you know, my parents everything, you know, I don't want to scare them. But that's not really the right way to do it, right? Because the patients, if they have the capacity to understand the information, you as a physician have the responsibility to let them know that. But also some patients really don't want to know. They want to, you know, they want their children to know and then tell them what's going on. So this is all depends on the patient. So you have to ask a patient, okay, how do you like to know the information? Do you want me to just tell you straight up the diagnosis, or do you want me to just tell you a little bit and then we can discuss a little bit more? But in the end, you have to give them the correct information. But this is just basically how do they want the information to be given to them, whether via directly to them or via their family members, via the children, or in a little bit of information, a small chunks of information, so they can cope with it. So you can ask them, so how would you like me to give the information, right, about the result? Would you like me to give you all the information, or do you want me to sketch out the result and then we can spend some time to talk about the result and the treatment plan, and then, you know, let them answer you. And then knowledge. Again, this is when you give them the information. This is when you give them the knowledge. Okay. Some patients have a very low sort of, you know, education level. So you don't want to give them all the information in a very complex manner. So you want to sort of give them a little bit of warning first. Say that, you know, unfortunately, I got some bad news to tell you, or you can say, I'm really sorry to tell you that. It kind of give them a clue so that they can be prepared that, you know, something bad about to happen. They're gonna, you know, hear something bad. All right. And then you should use very simple information. Do not try to use medical terminology. So for example, if someone had cancer, instead of saying metastasize, you can say the cancer has spread, which is easier for them to understand. Let's say if, you know, the biopsy shows, instead of, you know, saying that, you can say that, you know, the piece of tissue or the piece of muscle that we took out from you earlier, it shows something, you know. And then again, really avoid using, you know, excessive bluntness, mean that you just give them a very bad information directly upfront. Remember, trying to tease them into it, give them a little bit of, you know, like a warning. So I'm sorry to tell you that, like, you have bad cancer. Don't tell them that you have very bad cancer and unfortunately there's nothing that we can do about it and you're gonna die. This is terrible. And then you also want to give them the information at a very small, really a manageable chunk so that they can understand it. Because again, I don't know if you have anyone who, you know, have gotten news about cancer or some terrible news. The first thing you tell them that they have cancer, their brain just shut off and they don't remember or they don't, you know, register anything after that. So, you know, sometimes it's good to tell them a bad news and pause. You know, let them have time so that they can process the information first, right? I think that we are so accustomed to talk a lot, right? Keep talking, but sometimes silence is really good. You know, silence allow them to register the information and process their emotions. Okay. And then emotion and empathy. Again, this is when you observe in the patient, you want to allow them to have the ability or the time to express their emotion. You know, you should recognize their verbal and their nonverbal cues, right? If the patient are tearful, you know, let them have time to cry, give them some tissues, but don't, you know, interrupt that. Don't immediately jump into talking to something else. Let them really cry and, you know, really completely express their emotion first. And then you look for clues. If they're shocked, they're sad, you know, they're silent. The next thing is try to avoid giving false hopes. If their diagnosis is, you know, or their prognosis is not good, then you can tell them that is, you know, is they're not going to be able to completely recover. You have to be honest with them, right? If you don't know the prognosis, you really have to tell them that we have to wait for the specialists or for people who know about this to tell them about the prognosis. And again, you should use empathic listening and responses. So some of the responses that you can do is these empathic statements like, I can see how upsetting this is to you. I can tell that you weren't expecting to hear this. I know this is not good news for you. I'm sorry I have to tell you this. This is very difficult for you, but it's also difficult for me. I was hoping for a better result, but so these are the things that you can try to use, which is it's quite nice to have something in the back of your pocket you could use so that you could communicate with the patient more effectively. And strategy and summary. So basically, at the end of the discussion, you really have to check the patient understanding rate and make sure that you summarize every key points, making sure that everyone on the same page. And then after that, you plan for the next follow-up, whatever that you didn't discuss or didn't solve, and have a follow-up so that you can talk about it next. And provide them with additional support with like resources or written materials if available. For people who are religious, who is Buddhist or Catholic, you provide them with, whatever religious services that you have in hospital, so that they could, use them. And then last but not least, these are very stressful for the patient, but it's also stressful for you as a physician. So, sometimes you really have to check in your emotions. How do you feel after that, meeting? Always have time to debrief with the whole team. And then check your emotion and make sure everything is okay before you see the next patient. Okay, you don't want, that to, affect the next patient. Again, these are very difficult. So I think that, you have to really practice for this. The more you practice, the better it is. So this is it's a very good YouTube videos. If you guys are interested in it, I can post the link on Facebook, but it's go through the same process that we did, right? Using a spikes model. Okay, so I think the next Helens will talk about DNR, DNI, those mental capacity. So if you have any questions, you can talk about it now, or if anyone have any, experience or any cases that you recently delivered bad news or and you want to kind of share with the class, this will be the time for you to do that.
We do that at our, at towards the end at our wrap up.
Okay, sure. Then
I
I will
wanted to
hand it to
give them
you
an
then.
opportunity to practice the skills that you've talked about.
Okay,
Yeah.
sure. Then yeah. So
All right. I'm gonna go ahead and share my screen. Hang on a second. Bữa nay đó thì chương trình mình thay đổi một chút. Đợi. Okay. Let me share my screen. Bữa nay chương trình thay đổi một chút thì cảm ơn bác sĩ Hùng đã vừa trình bày. Bây giờ mình sẽ vô breakout room. Hôm nay thì mình sẽ tập ở trong practice room khoảng 45 phút. Cái sau rồi mình sẽ quay lại với nhau thì tôi sẽ trình bày thêm về decision making. Ok. Thì bây giờ cái breakout room là đây. Thì mời các bạn vô breakout room.